Welcome. My name is Melissa Arabadjief. I am a second-year psychiatry resident, and today I'm going to be presenting a journal article discussion entitled N2 Responses in Youth with Psychosis Risk Syndrome and Their Association with Clinical Outcomes. This was a cohort follow-up study, and it was based on a oddball paradigm using a three-stimulus visual program. And if that sounds like a mouthful, it's okay. I will be breaking it down. Oops. So objectives for today, just briefly touch on the disease burden of schizophrenia that this is all tying back to, review the concept of a prodromal period in schizophrenia and specifically psychosis risk syndrome, as well as some people may see it as attenuated psychosis syndrome, and the subgroups that are connected with that. I will discuss the current methods and limitations that we have for predicting the psychosis risk syndrome and conversion to schizophrenia and other psychotic disorders. And then we'll dive deep into the analysis of the article in question. Specifically, I'll be talking, reviewing the purpose of the study, the hypotheses, methods, data analysis, and ultimately results. And with that, we'll dive into a discussion about whether or not the hypothesis could be accepted or not, and then the strengths and limitations of the study and how that can be used to guide our approach in researching these patients and also treating youth who have attenuated psychosis symptoms and are at risk for schizophrenia. So schizophrenia, I'm not going to go into huge detail on this because Dr. Good just did a wonderful grand rounds on this, but we get really connected with the positive and negative symptoms and recognizing those in patients who have schizophrenia. But as some of us learned in didactics, this really was initially viewed as a cognitive disorder. Emil Krepling, gave the diagnostic term dementia praecox, which eventually was renamed as schizophrenia. And the connection with that dementia is that this is more of a developmental dementia occurring in the setting of synaptic pruning. So when we think about schizophrenia patients, about 80% of them have cognitive symptoms, and we often think of this as more of a disorganized factor in patients. There is a direct correlation between the level of cognitive performance in patients with schizophrenia and their real-world functioning. And cognitive impairment then correlates with disease burden to society because oftentimes these patients are not adherent with treatment and they have greater likelihood of hospitalizations, which ultimately is more cost ineffective. Ultimately, when we look at the top 10 medical causes of that lead to disability, schizophrenia is up there. So just looking, I came across this in my research, and interestingly, this is a pretty growing area of interest. If you look at the PubMed article searches, specifically focusing on the cognitive impairment in schizophrenia has significantly grown over time. So some things to keep in mind as we go forward. So current challenges are that we have these tools right now to identify youth at risk for psychotic disorders. I'll refer to that as psychosis risk syndrome or attenuated psychosis syndrome. But once we identify those youth at risk, there's a really poor predictability in actually who of them will convert to schizophrenia. And because of that, we're kind of limited in what we can do with them because the current treatments that we have, although many of you guys have seen recent articles, there are a lot of the treatments that we have right now have a lot of significant risks with them and balanced with kind of modest functional gains. So to give somebody who may not even convert to schizophrenia, it becomes a real challenge. And even if we were to treat them, we still have a shortened lifespan of about 14.5 years. So there really is a significant need for reliable biomarkers, and the goal would be to go with brain-based biomarkers to predict who in this at-risk youth group will then convert over to a psychotic disorder. And then from there, which of these can we then maybe use to then predict the sensitivity to these new novel interventions and treatments that are in the pipeline. So kind of just some visuals to kind of put this all together. About 80 to 90% of patients with schizophrenia have a prodromal period that is in the like 1 to 5 years before they actually meet diagnostic criteria for schizophrenia. We find these patients, if they were picked up, may have been given the term psychosis risk syndrome or attenuated psychosis syndrome. It's not a DSM-5 diagnosis, but it is a term used for research purposes. For criteria for that, they have to have at least one positive symptom, but they are attenuated, meaning they're less frequent. But oftentimes they present because there still is distress or disability related to that. But again, they don't meet any of the DSM-5 criteria for mental disorders or psychotic disorders. Sorry, mood or psychotic disorders. So attenuated is given as the term in DSM-5 under terms to use for research, because they typically only have to have symptoms at least once a week over a month period. It has to have started or worsened in the last year. But what's interesting is a lot of these patients still have reasonable insight into the situation. So when we look at the patients who we qualify as at risk in the psychosis risk syndrome, we're using several different interview tools at this point to identify them. So we think about SIPS, which is a structured interview for psychosis risk syndrome, the SOPS, which is a scale to then rate the severity of those prodromal symptoms, and then a mini test. With those, though, again, most of them do not go on to develop schizophrenia. So only 1/4 of this whole group of the psychosis risk syndrome, or PRS, actually go on to meet criteria for schizophrenia. That means 75% of them don't. And that's where we run into these issues, because at this point, we're not comfortable with treating them because there is such a high risk of adding morbidity with the treatment than preventing morbidity from a psychotic disorder. And again, this is a breakdown. Typically, we're looking at about, they say on average 25, but anywhere from 15 to 36% of patients who fall into that psychosis risk syndrome go on to convert to schizophrenia. So when you hear about the conversion, we're talking about schizophrenia. About a third of them will actually remit completely on follow-up scales. And then about another half or so will develop some other kind of non-psychotic disorder or still be symptomatic without a diagnosis. So with that, this article specifically is trying to identify a better biomarker tool. Okay. So let's dive into this article and look at if it can actually do that or not. So how et al. Started this study, their goal was to identify, like I said, the biomarkers. They're looking at brain function and trying to figure out if they can, within this group of patients who have psychosis risk syndrome, can they find some change in a stimulus test driven test to show that somehow they respond differently, that their cognitive response is somehow different. One thing that's unique to this study is that they focus specifically on visual stimuli. A lot of previous studies have focused on auditory stimuli in patients. Another thing is that they actually try to kind of make a more robust demand on the subject's attention during the task. And they did that by actually adding 3 categories of stimuli, and I'll go into that. And then When they collected the data and the brain functional response, these ERP waves, they actually looked at more components of that wave than what has been traditionally looked at in the past. So typically just P3, but they're looking at additionally N2. So ERP, so this is the data that they're collecting from these patients who undergo this stimulus paradigm or study. So they're looking at every time they present a stimulus, the EEG is locking in the response, this summative activity of postsynaptic potential, and they can then chop that into kind of segments based on when a stimulus is presented and what the brain response is. It's a very nice test because it's safe and non-invasive. And then for our purposes, it kind of directly correlates or connects with the cognitive function of these patients. So like I said before, this study specifically looked at both the P3 and N2 component. Like I said before, most of the previous studies have focused solely on P3, which is a large voltage component, but they kind of ignored another pretty significant large voltage component, the N2. And when they looked at N2, there's an additive uh, opportunity to look at the selective attention towards IND of targets. So I'm going to kind of talk a little bit about these because it can otherwise feel a little bit overwhelming. And then we'll get into the study more. So N2, so this whole wave here is this event-related potential ERP waveform. So there was some stimulus that was presented and then the brain responds. There are multiple waves. And an N wave is a part where you have a negative deflection. And when we look at N2, we're looking at the second one in the series. What they look at for N2 is that it specifically looks at pattern recognition and the ability to ignore stimuli that are not of target. And then they looked at the latency and amplitude. I will tell you that the amplitude ended up being more important in this, but they're looking at the response to recognizing an odd or unique targeted stimulus, and then how much attention you could give to that. And then the P3, it's not negative deflection, it's a positive deflection, so we call it P, and it's the third positive deflection in that specific ERP. And this looks at how much attention's actually allocated to once you identify a stimulus and its importance or non-importance with the N2. And then you kind of refresh the working memory for the next one. Again, they looked at the latency and the amplitude of that. And again, the amplitude ended up being more focused on at the end with the idea that you have greater attention being given. So the study that they presented that had the patients go through was called a visual oddball paradigm. And it's visual because the stimulus is something they have to see. Oddball is because there is alternating stimuli. There are some that are less frequent, and that therefore is the oddball, and it's actually the targeted one, the one they want them to pay attention to. So the other ones they should ignore. So you can kind of see here, the green one is the targeted or oddball one, and they're supposed to click the space bar. A 3 stimulus one means that there's still one that's targeted, but now there's two. There's one that's kind of a base one that's more common, and then a random kind of distractor. So here you could see a random distractor. So again, just to kind of refocus, this study's objective was to focus on visual attention to attention processing in these patients who have psychosis risk syndrome. So these youth who are at risk for schizophrenia. And then with that, they're looking at the responses in their ERP. They're looking at their attention and how that's affected when they add in not only a targeted and a background, but now an interference stimuli. and then specifically looking at, can they see a difference in those waveforms, the N2 and the P3 components, to somehow correlate to the outcomes of these groups after a 12-month period. So did they convert to psychosis? Did they remit completely, or are they symptomatic? So when we look at the hypothesis of the study, they had three. The first one was that individuals with the psychosis risk syndrome would have a much more significant N2 and P3 amplitude deficits. So their attention would have a deficit, so a shorter amplitude compared to the healthy controls. And then they broke it down into patients who had specifically psychosis risk syndrome, and based on their outcome subgroups, what their N2 and P3 amplitude deficits were. So they predicted that, or hypothesized that, those who converted to schizophrenia would have more baseline N2 and P3 amplitude deficits or problems with attention, and then compared to those who would either remit or remain just symptomatic but not meeting criteria for DSM-5 diagnosis. And then those who did remit would have ultimately less baseline deficits in the N2 and P3 compared to those that converted. So to do that, we'll kind of look at the methods, so who they got, what the procedures they went through, the processing with the EEG, and then ultimately, and kind of focus on the statistical analysis. So the participants, so pretty impressive. So this was based in China, and they used 3 Chinese universities. They got almost 9,000 freshmen to complete these surveys. They were quite a few. And from that, they were able to collect from that 223 participants to either fit into one of 3 categories: the psychosis risk syndrome, the emotional disorder group, or the healthy controls. And then it was about half of them were in the PRS, and then the other half were divided into emotional disorders or healthy controls. Interesting, the emotional disorder patients had to have both anxiety and depression symptoms on our scales. Of the psychosis risk syndromes, they're using the traditional interview tools to categorize them. So the SIPs, the SOPs, and the MINI. And then this is kind of example of the SOP. So they're looking at the category of symptoms and then the severity of that. And then if they met criteria for the PRS using those tools, they then had to not meet exclusion criteria. And basically these were anything that can affect or cognitive function other than a psychotic disorder or something that might suggest they already had one. And then they also, because it's a visual, they had to have absence of color blindness. So these patients, the 122 PRS, they then went back and did a reassessment afterwards with the SIPs. They only lost 1 patient to follow-up, which I thought was pretty impressive. So of the 223, they had, of the 122, they had 121 in the follow-up. And then they broke them into whether they still met criteria. They would be the symptomatic, those who remitted, and then those now who met full criteria for psychotic disorder. So from these patients, whether they were the PRS, the emotional disorder, or the healthy control, they all went through the same stimulation procedure. And again, it's this 3 stimulus oddball. So you have a standard stimulus, which is presented more frequently. It's supposed to be an average of 70%. Then they do a target stimulus, which they're supposed to respond to if they see it. That's 15%. And then there's another additional 15% of just interference. So they're not supposed to respond, but it's not seen very frequently. They would do a 280 trials of that. So I just wanted to kind of give you a little bit of a visual of what this looks like. So here's somebody doing, so they're doing a two stimulus one. So they're supposed to be ignoring this background, and then they're supposed to be responding to the red. So every time they see the red, they're supposed to hit the space bar. And then they'll look at the waveforms every time one of these stimuli pops up. They look at the waveform for that and then calculate the average. Stop that. So to do that, obviously they need an EEG. You can see from the image. They had to be free of any substances that might affect an EEG. They use 64 channel electrode cap, and then they segmented that EEG based on each of the stimulus events. They would then calculate the average ERPs for the targeted and then the standard. So the target is the one they're supposed to respond to, standard is the one they're supposed to ignore. And including the interference one. And then from that, they would create an N2 and an N3 average waveform. And they could then look at the latency as well as the amplitude. So result-wise, looking at the whole group of freshman Chinese students, they're pretty well matched across the three groups, the psychotic risk syndrome, the emotional disorders group, and the healthy controls. The only thing that was a little bit that was statistically different was economic status, but that was not further elaborated on. So when they look at the results, I just want to I'm going to break this down, but they have the ones that are looking at the the N2 wave and then the P3 wave. And then they're looking at, you can kind of see down here, the attention response that you're getting in the amplitude of the response in the images below. So we're going to break it down first into the results, specifically comparing the risk group, the psychosis risk group, the emotional disorder group, and the healthy control. And then again, we're going to have to use ANOVA analysis to do that, and I'll explain that. So when they look at the N2 amplitude for between these three groups, they were able to see that the psychosis risk syndrome had a statistically less negative or lower amplitude of the N2 wave compared to the healthy group. And then when they looked at the psychosis risk group versus the emotional or the healthy control, they were not able to see any statistical significant difference, but there was kind of a graded change between them so that the emotional fell between the PRS and the healthy control. When they looked at latency across N2 and P3, there was no statistical significance. And then for the P3, interestingly, whether it was amplitude or latency, there was no statistical significance in the P3 wave for any of the groups. You know, this really stood out in the study because all of the previous oddball paradigms looking at psychosis risk syndromes, they were looking at the two stimulus paradigm, and they in general reported a significant deficit in the P3 amplitude in those studies. And more often in those, they're looking at auditory. So it's just kind of with the visual and then also adding in an interference or third stimulus, that separation didn't occur in this study. In the past, they were trying to make the argument that a shorter P3 amplitude was associated with a shorter onset time to psychosis, but this is arguing that may not be the case. And then when they looked at, so in the follow-up 12 months ahead, they did the surveys again for the psychosis risk syndrome patients, and they were recategorized into 3 subgroups. They were either now meeting criteria for schizophrenia, this conversion group. They were remained to be symptomatic and still qualifying for PRS, or they were in remission. And then they were then compared to healthy controls. And when we look at this, we see that only about 20%, about a fifth of patients within psychosis risk syndrome group actually converted. And then about a third of them would remit, and the remainder would be symptomatic. With that, they were able to see that patients who converted to schizophrenia had a significantly less negative N2 amplitude. So their ability to attend to this oddball stimulus was somehow less. There was less attention given to that compared to the other PRS subgroups. And that included both the symptomatic and the PRS. So this is kind of the first time we're seeing this PRS group where only, as little as 20% to as much as like a quarter or third of them might actually go into psychosis or schizophrenia, sorry. This is the first time we're able to actually kind of predict who they might be. And then when they looked at the conversion group themselves, again, which you kind of expect, their N2 amplitude was significantly less negative than the healthy control group. So it was not just within that group. And then when they looked at the PRS subgroups that were symptomatic or remitted, so they're less negative than our conversion group. They still, even though they maybe even improved and remitted, they still had an initial N2 amplitude that was less than their healthy control counterparts. So when we look at the latency, again, as mentioned before, there really wasn't anything statistically significant, whether you're looking at the original groups or the subgroups at the end. And same thing with the P3 amplitude and latency. So in that conflicts with those prior studies, there was no statistically significant change in the amplitude of P3 that was anticipated. And then interestingly, so, the ANOVA studies are meant to be able to look at the average, compare the average or correlation between different groups. And then on top of that, they then looked at the N2 amplitude of these groups, and then did another analysis of the symptom score on the SOPs, so how significant their symptoms were. And when they looked at the positive symptom score, there actually was an inverse relationship. So the more positive symptoms, which would make them have a higher PRS, like easily fall into that group, their N2 amplitude was lower. So kind of looking at all of that, what do we do with this information? So ultimately, I think sometimes we forget to do this. I will admit to be guilty of this. We kind of forget to look at the original hypothesis and what did we actually figure out? We have findings, but how do they relate to what we initially thought? and what questions that bring about. So when we look at individuals who have a psychosis risk syndrome, we hypothesize that they would have a significant N2 deficit compared to healthy controls, so that original group evaluation, and that did happen. But when we looked at the P3, which in previous studies they had a deficit, we did not see that. When we then follow up 12 months later and now look at just the psychosis risk syndrome patients and their outcomes at this point after 12 months, whether they converted or remain symptomatic or remit, we hypothesize that those who converted would have a greater baseline deficit in both N2 and P3. We did see that they did have a more pronounced baseline deficit for N2, but what we expected based on prior studies, we did not see that with the P3 amplitude. And then looking at individuals who remitted, we would expect that looking back 12 months before, that maybe their baseline N2 or P3 amplitude deficits would be less pronounced than those who converted. And what they found was that that did not happen. So when we think about discussion and kind of points to take away from this, we think about what's like unique about this study and what you might want to take forth in future studies. So they kind of built off of and tried to minimize variables that might confound the outcome when it comes to the paradigm study and the stimulus. And then they also tried to add in something, a further cognitive challenge that without adding variables that would potentially strengthen that or broaden that separation between when we look at the ERPs of these patients, that biomarker in the brain. So they used an interference stimulus in addition to a frequent background ignoring standard, and then the infrequent oddball, which they were targeting. And again, we see that increased attentional demands. And with that, the PRS patients had a harder or had a less ability to provide attentional demands to that. And then when it comes to the 3 stimulus oddball paradigm, it's not unique. It's been done before, but oftentimes they add in variables that can be confounding. So they change color and shape. And here they tried to specifically focus on color. So size and shape were the same. And then with that, going through those changes, we found that the P3 amplitude differences that were seen in previous studies were no longer statistically significant when you added in that infrequent target stimulus. And then now you have this added ability when you look at the N2 wave, which had previously been ignored because it was not as big as the P3, but it ended up being the one that showed a statistical significance and its deficit to be able to take that group of psychosis risk syndrome patients, these youth who can we treat them, can we not? Are they going to get any benefit from it? Can we, looking at these different potential treatment strategies, we didn't have any way other than guessing who would be most likely because it was such a smaller group that actually went on. So this is the first time we can use an N2 amplitude deficit to stratify this psychosis risk syndrome group with some more evidence. And then the other thing that they did, which I didn't touch on as much before, but I do want to point out, so they added an emotional disorder group. So in that original group, they didn't just have a control and then our PRS group, they had an additional mental disorder group. And the idea behind that was that a lot of youth that present with concern for psychosis and prodromal phase often have a lot of comorbid anxiety and depressive symptoms. So looking to see if there's an overlap between them, or do they stratify when we look at these biomarkers? So it was, I think, a helpful thing looking forward to future studies when we're kind of trying to separate those groups in the future as a way to do that. When it comes to limitations, just in general, you have to keep in mind for any prospective cohort study that because you're going forward, you take all this demographic data in the beginning. A lot of times we don't follow up and things can change. A patient may not have been using a substance earlier, but they might not disclose their use along the way. So there's potential covariables that can confound your data as you go forward. Also, just because you're having to do a lot of work up front, meeting with patients, doing all this analysis and stuff like that, it can be very need provoking, a lot of high costs and effort up front along the way. And so oftentimes they tend to be smaller studies, which in our case, we saw that as well. And then they often are only using a single site. Ours had 3, but ultimately, if we want to take this new information and try to, apply it, we first have to do additional prospective multi-site larger population cohorts, which is going to cost money and time to do that. The other thing, so in the DSM-5, under these kind of syndromes to consider for research purposes, they didn't use the term that's in there, which was designed specifically to create this common language in research. And their description was fairly detailed, but not quite enough that it was not 100% certainty that they're using PRS as an equivalent to this attenuated psychosis syndrome. So just keep in mind, if you're doing research, to really try to honor the expert consensus terminology so that there can be common language between researchers and clinicians while they're trying to study these developing syndromes. And then when it comes to the N2 amplitude, so it suggests that there's some way to stratify, use it as a biomarker to stratify the PRS patients. But the question is, how much can it do that? And so a lot of people are finding that they're having to add multiple different biomarkers together to kind of create an algorithm to get a high enough, predictable biomarker potential, and they use like conversion calculators. So looking back at the data, if you look at the effect size, when you're comparing the conversion versus symptomatic group or conversion and remission group, and their N2 amplitudes, the effect size wasn't negligible, but it wasn't over 1. So it's likely that it's going to have to be bundled with other biomarkers. So we still have to develop them. We can't just look at this one. And then when we look at these youth that we put under psychosis risk syndrome, and we now have this N2 amplitude deficit to kind of stratify them, I guess the question is, what do you do with that now? Because a lot of people argue that, especially when we're looking at younger people, what's the risk benefit ratio here? And, a lot of people argue that our antipsychotics are still not doing enough. We only get modest functional gains. And then we have these significant risks like metabolic syndrome. And so the question is, do we go ahead and treat them, or do we need to find other treatments? And so I think that's where, kind of look at it as a benefit, and the counter argument is that knowing that this limitation still exists, even though we have a way to stratify them, we don't know what to do with them that we feel comfortable with. It now puts more emphasis and research to support developing further treatments. So, what I don't know if you guys are familiar with this, but there is a link here, you can click on it, but there is a partnership that's specifically looking at trying to look at these patient groups and include them in novel therapy that they're developing. And then I know amongst the residents, there was conversation yesterday and then in KPMA recently, and lots of journal articles about the CART XT. And so, looking at the biomarkers, maybe we can go back and maybe add some evidence for the pathway that leads to these cognitive deficits, and therefore come up with more novel treatments that might better address something that has pretty significant functional implications for the patient. So thank you for your attention. Any questions, comments?
Thank you, Dr. Arabadjief. If you have a question, please use the raise hand feature and I'll promote you to a panelist.
Mel, can you hear me?
Yes.
Okay, great. No notes. I just want to say, younger residents, pay attention. This is how you do a journal club. This is completely hits like all the marks. So thanks for doing a great job on such a topic that obviously I love so much, but is so relevant to our field right now.
I have a question. It's maybe a little bit more adjacent to the topic, but I think still somewhat relevant. I remember I was listening to a podcast about a year ago, and they were talking about this psychiatrist that was down in Australia that was taking patients whose family members had a very strong family history of schizophrenia, and if he kind of assessed the signs in early childhood, he was putting them on a low dose of an antipsychotic and then following them long term. Do you ever see something like this being used to try and see if we can like prevent the development of schizophrenia? And I don't think it would actually end up preventing them from happening, but it might make it clinically masked or at least make the symptoms so manageable that it's functionally like they don't have it. Do you think that could ever happen, or do you think that's just there's too many variables?
So, I mean, I think that ultimately is the goal of this kind of study, is that right now we just know we're waiting and watching for them to like pop into this, full-blown psychotic disorder that we can justify the risk and benefit of treatment. But if you can find biomarkers that can kind of suggest kind of the genesis of these symptoms and this disease process, and Dr. Good did a great job of like talking about all the different, potential mechanisms for schizophrenia, that if we can collect more biomarkers to kind of lead us down a medication pathway that seems more plausible to have an impact, then I think that people would start to argue, because it used to be my understanding, and I just don't have a reference for the prior DSM, enough capacity to, but my understanding is that the psychosis risk syndrome, like people used to like argue treating them, and then because it was in there, and then they kind of backed off and recategorized them and like, listen, we want you to study this, but this doesn't mean it's not a full-blown Section 2 diagnosis, so you shouldn't be treating it. And I think that was because there was, all of that comorbidity that come with medication. But I think if you can justify that there's a more likely positive outcome and a benefit, then it would push people to do that. And I think that once you identify these biomarkers, I think it's going to drive not just treatment research and the impact of it, but also kind of re-looking at, can we clarify what's the process that's causing positive, what's causing negative, what's causing cognitive symptoms. And then based on how these, you could look at the SOP score and then maybe, justify those treatments. But I think, people are always hesitant to treat young people when they aren't, 100% feeling, like we got all figured out, a lot of it figured out. So I think this opens that door to getting people closer to that point that they're willing to do those trials.
All right, well, thank you. I thought that was a great answer.
Any medical students with questions?
Can you touch a little bit, Dr. Arabadjief, about how they chose the sample?
So they specifically just were trying to get what they would consider to be to have both psychotic mood and healthy controls. They looked at youth, so they specifically targeted, because it was a prospective study, they knew they were limited with like site. They specifically like chose the university students to do that, knowing that they were, and they picked freshmen, so a little bit younger. They would be able to follow them through for at least a year. I think they had 18 months was the total time for the study, but the 12-month pre and post SIPs, evaluation. So, the goal would be is that you could get a pretty representative population. The question is, there's obviously some discrepancy in significant, like statistical significant, like difference in, I think it was economic settings. So I guess you would have to question about what were the specifics of the universities they picked and what patient population they're drawing from, if they were a representative of local community, or did they import people from lots of different places with specific like focus. And that wasn't alluded in the article. So I think that's where looking at multi-site like investigations of follow-up is going to be really important.
Thank you. Yeah, I think this is kind of lots of effort were put into this study. A new publication, I think it needs a lot of validation though. Sometimes we have to approach the Chinese studies with a lot of caution about their data collection, about the verification of it as well. But thank you, that was a wonderful presentation. Kind of difficult and complicated, but you did a great job. Thank you.
Yeah, thank you.
Any other questions for Dr. Arabadjief? Well, thank you all for attending today and hope you enjoy the rest of your day. Thank you.